It's time to enhance the relationship between expertise and impact, between knowledge and application. Welcome to a journey of discovery and empowerment. Welcome to All Physicians Lead, the Forbes Books podcast that highlights the critical leadership role that all practicing physicians take on every day. Here's Dr. Leon Moores.
I'm back with Owen Dahl, who's been sharing his journey from managing rural hospitals to becoming a consultant focused on improving physician practices. Owen, in part one, we touched on how informal leaders within organizations can play a significant role in driving influence. When you've observed organizations that excel in implementing transitions, I know you don't like to refer to them as changes. Transitions is great. What stands out? When I say that, when organizations aim to improve processes to benefit patients and teammates, what are some of the key traits, skills, approaches, et cetera, that you've seen physicians adopt to engage and lead during these transitions?
Well, one of the keys on that whole thing is just simply communication, and as we know, communication is mostly is what your tone of voice is and what your body language are and those kinds of things, more so than the words that you use. And so as we think about this, how well does that physician or that leader communicate with the staff or with the patient? And instead of, I'm looking at my keyboard and I'm trying to tell you, well, they take this medicine. Well, what you're doing is you're seeing the top of my head. Well, the body language is not going anywhere, so that kind of thing can get in the way. So a trait that's very important is communication. Another trait that I always like to think about in terms of relationship is power and who's in the power position. And what happens, unfortunately, is many people that are in that power position, that upper level, that strength kind of scenario, they use that as too much of an authority. And they become dictators as opposed to communicators, as opposed to interacting and engaging with. So communication with that power position leading to some type of engagement or lack of engagement, all of that leads to, well, there are several other factors, what are our goals in terms of organization or my interaction with a patient or your interaction with a patient as a physician? What are the mutual goals that we have? What's the power position? And those in the communication, those kinds of things really lead to something that's probably the cornerstone of any leadership engagement is trust.
I'm a huge fan of Stephen M.R. Covey's book, The Speed of Trust. I think that is just a classic. Anyone asks me, what should I read on how to be a better leader? That's one of the first ones I throw out.
Yeah. And so, all these components, the communication, the engagement, the composition, the mutual goals, those kinds of things lead to that building of trust. And once you get to that building of trust and have that trusting relationship, well, what happens after that? Well, compliance, collaboration, and cooperation. So what that whole concept then goes to, what we're really trying to do is to get that patient well. And how do we do that? Well, the patient needs to be compliant, but my team needs to be compliant. My team needs to collaborate. The patient needs to collaborate. How does that happen? It happens because I trust what you're doing. And as you defined, when I first started out consulting, and I would go into a practice and I'd say, well, I need to do an evaluation to tell you what's wrong with your practice and what's right and what we can do to improve. Well, I could take 3 or 4 or 5 days to figure that out. I can go into a practice today and probably within an hour and a half, I can tell you where there's this problem, this problem, this problem, and this problem. And it's that culture, it's that ambiance, it's that engagement that's right there. So there are differences. And even in this process that I described, going to certain offices, I could sit there and wait for 45 minutes. And as you mentioned earlier, the timing that goes on and so on. Well, why am I waiting for 45 minutes? Because the office is discombobulated. We use that word. And
one of my favorites.
And how do you do that to make that office that become much more efficient? And so you think about those kinds of things, and it all gets back to what's your goal, what's your purpose. I like to think about what I call the four P's: the practice of medicine. And well, why do we call a medical office a practice? Well, it's because you're practicing, you're learning every day. Okay, so you're really in that practice mode. Well, what's the next thing? What's my purpose? Well, my purpose is to take care of patients, so to make sure that they're well and get that outcome that's necessary. Well, what's the third thing? The third thing becomes the patient. So you got a practice, you got a purpose, then you have a patient. Well, if these two don't work, what happens to the patient? And then the other thing that everybody thinks about in the medical world is profit. Well, the profit is number four, it's not number one. So if you do your practice, your purpose, your patient, you'll get profit. You'll be financially successful. But you don't get to be financially successful unless you do these other three things and have those oiled, collaborative, trusting relationships that lead to getting that bottom line.
Yeah. Great lesson. Great summary there. And so following along with that, you have had many experiences doing those assessments and making recommendations. Give us one or two or three examples of, for our listeners out there who are, running their practices. Tell us the art of the possible here. Give us some concrete stories where you've gone in, you've seen this, you've implemented this, you've had great cooperation, and this was the outcome.
Which one do I pick first?
Yeah. There's meant so many.
Yeah, and a lot of that goes back to, again, frankly, how I communicate with them. Okay,
Okay.
in terms of, hey, this is an issue that needs to be addressed, and so on. And but again, when I was a hospital administrator, I was on this side of the desk trying to tell a doctor something, and they would never listen to me. Now I'm on this side of the desk, and I'm telling the doctor something. They're paying me. They're going
That's
to
right.
listen.
Yeah. They've invited you in,
Yeah,
right?
yeah. So they're going to listen to me, and that makes a big difference. So uh, we've experiences we've had cleaning up the revenue cycle. Okay, improving reducing the number of denials that you get when you submit a claim, improving your collection percentages from what your net collection percentage is of X to Y and that sort of thing. And so, in those particular kind of cases, looking at the revenue cycle, work mostly with the staff, but a critical component of that is the physician. So you have to talk to the physician about what the coding levels are and how the documentation is and that sort of thing, and what can be done to improve that. So how do we improve your documentation? How do we improve your decision making relative to the coding level that's appropriate, so that we don't get the denial because the coding level didn't match the CPT code didn't match the ICD-10 code, and so on. So you look at those specific kinds of examples, you can see anywhere from 10 to 25% improvement without doing a whole lot in terms of reducing those denials and improving your cash flow and that sort of thing. Another set that we like to look at is that cycle time of the patient coming into the office. If you look at every patient that you see in a clinic session, let's say you start at 8 in the morning and you finish, your last patient is assigned at 11. Well, that first patient at 8 o'clock in the morning could be seen in 20 minutes or 15 minutes. That patient at 10:30 is seen in an hour and a half. Well, why is that delay there? What built into that whole cycle? So what we do is we take apart that. So, like, I can't give you a specific example that says we did this in office A, B, C, D, and E, because we've done that in so many different offices to try to look at where those gaps are and what can be done to help improve that flow of the patient or of the patients going through that. So as you think about this, those are kinds of things. Other things that we've been able to do is helping make decisions relative to purchasing the various equipment, ancillary equipment that you might be bringing into the office. So you want to try a new particular kind of thing. Do we want a CT scanner for the ENT office? Well, Yes or no? Well, what do we do with that? So the kind of specifics that we've been able to do is to drill into looking at those things. And how does that get done? Well, it gets done by looking at metrics. It gets done by communicating. It gets done by looking at those kinds of things to try to have the practice make a decision about where we go. One of the other bigger things that we work on is, frankly, compensation. Yeah. How does the compensation formula work? Do you use relative value units? Do you equal share? Do you do this? Do you do that? I was thinking about that earlier. One of the groups that I worked with several years ago was a four-doctor group, and the senior physician was the owner of the practice or the principal owner of the practice. He had three junior associates, which were all owners or on the ownership track. And question of compensation came up. How do we do this? The leader of that practice said, we're all equal. We're all contributing to this group. I'm not better than anybody else, and no one else in here is better than anyone than me. And so, here's a senior physician saying, I want to share equally with everybody. Most of the time, it's a senior physician saying, I want more than everybody else.
Sure. Yeah.
And how do I get more? Well, I get more by work, by relative value units, by production, by number of new patients, whatever the formula develops. So I've had those kinds of experiences. So from anywhere from managing the revenue cycle to the patient flow to purchasing of different equipment to compensation, those are the kinds of things that. And again, I'm not giving you a specific. Here's one that I
No, it's
got
fine. This is good.
80% benefit from, but the point is that those are the kinds of things that the leadership needs to recognize that they either need to bring in outside support or they need to do another thing that you emphasize in your book, which I think is very important, is the aspect of education and networking. And what can you do in terms of educating? Well, I can educate the revenue cycle manager to improve that. Well, and then again, back to what goes on here. If I'm going to recognize my revenue cycle manager as part of my team, where does all of this start? Well, it starts at the front desk. Are they part of the revenue cycle team? Well, no, because the back office is the revenue cycle team. Front office is here. So we got two silos. What are we going to do with those silos? We got to put them together in order to get that denial rate to be improved. And so if we don't recognize that, and then if we don't train the staff, if we don't do things to help make them more efficient themselves, what are we going to do? So communication, yada, 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 that we talked about earlier, couple that with a willingness to pay for and to contribute to education of your employees. And as a part of what you bring out and is as well, is that there are different organizations, American Association of Physician Leadership, AMA, different organizations like that offer what? Well, they offer education to physicians as well as managers that help them develop themselves and become better leaders and better managers as they move forward. And I don't think we should just look at your CMEs and say, well, this is where I have to focus my education. We need to look at what can we do to develop those physicians, especially those that show those leadership traits to help and the circles that you talk about, yourself, others, team, and then the organization. Well, what can we do to help get them to be at that organizational leadership level? We do that by education, by mentorship, by coaching, by doing those kinds of things to help all of that come together. Now, I think that's necessary to make that go.
Yeah, and those are good investments, right? I mean, if you show your teammates that you care about them, you're willing to help them get additional education and grow their toolkit, then retention, engagement all improve. And, that's a very difficult thing to calculate out the ROI of, but retention's a huge cost in healthcare. Folks are very mobile. And, if you have a 15, 16, 18% annual turnover rate, that's an enormous cost. So those are great. Those are great thoughts. When you've seen teams implementing some of your programs, you come in, you do the assessment. where specific to physicians, but certainly other team members as well, are the biggest pitfalls that you see, the traps, the challenges that folks have in implementing the recommendations, and how do you coach them to avoid those pitfalls?
That's a good point. How you bring that up. One of the things that's really necessary uh, to to succeed with the implementation of these transitions that we want to do is to find a physician champion. And especially when you're talking about physician leadership and how that works, I want to go to the physician champion. I want to go to that may be the informal leader, maybe the formal leader, but it's someone who has a good understanding of what I'm suggesting that they take a look at, accepts that peer-to-peer relationship makes a big difference in terms of implementation. I've seen too many times where I've been to groups and I've done the presentation and they talk about this and they say, well, okay, 4 of the 5 recommendations are awesome. We want to do 4 of the 5. Fine. You don't have to take all 5 of my recommendations. I understand that. But so you take 4 of the 5. Everybody in the room, I support it. Yes, let's do it. What happens? Without peer relationships, without somebody taking the lead to help that implementation of it,
There's that word again, right?
you get you get the passive aggressive behavior. Okay, I'm supporting it, but the next day, hell no, I'm not going to do that. Okay, so you really need that. You need that continuing sort of coaching, mentorship kind of thing in order to go forward with the implementation of any recommendation that I may have made or that others would have come up with. And a big piece of that is when you think about transition, if you say to people, do it this way, it took you 5 minutes to tell them to do it. How many weeks will it take for them to implement it? Whereas if you say to everybody, let's get together and talk about this, let's make sure we're moving forward. So let's engage those that are going to implement the transition to the new way of doing things. It takes a lot of time to do that, but the implementation phase gets back to 5 minutes because they bought into it. So when I end up with a set of recommendations and so on, I'm looking for that leadership, and then I'm looking for the opportunity to make sure that there's coaching, mentoring, and training that goes on that ensures that that implementation will be done. Rather than being, again, a dictator, I want to be an engager, getting people to be able to do that. So in order to be assured that the recommendations that I make are implemented, I'm looking for that to be able to have happen. The group that I worked with here in the Houston area, I worked with them for a number of years. What we ended up doing, we had the physician leader was awesome. I mean, he was very dynamic, very well respected, very trusting, a good communicator, and so on. But his support staff was weak. We ended up being able to recruit a really good young man. Just happened to be a guy. Could have been a gal, but in this case, it was a guy. And the two of them connected very well. So the physician and this uh, lay leader became a great dyad in terms of making things move forward. They saw the need to be able to implement things by working within the structure that was there. So we would have meetings with doctors, we would have meetings with the staff, and so on that talked about what changes need to be done. The staff was enabled. We actually got many of the staff to become white, yellow, green belts in terms of the Lean Six Sigma world. So the enabling that came out, in other words, the culture of that practice was such that that practice grew from 15 to like 30 doctors, and not just 5 locations, but like I don't even know. I haven't worked with them for a couple of years, so I'm not sure who they are right now. But they ended up with a significant growth pattern because they had the culture that was there, the engaged culture, the effective communication, the confidence and trust that built by that dyad to really make things come together. And so that was just an awesome thing to see and to recognize that what they've been able to do.
Yeah, that's impressive. It's fun, right, to be engaged in something like that. You're making a difference. So Well, we're here with Mr. Owen Dahl, over 4 decades of healthcare leadership experience and consulting and trying to make things better for our patients, teammates, physicians. Last thoughts, if you wanted to leave everybody with the words of wisdom in a couple of minutes, where does this all sum to, and what do you want to leave us with?
I think it's really important for the physician to recognize that they are leaders, and they have that obligation to their patients, but to their team. And they need to recognize the contributions that they are making in those regards. But I also think it's really important, in going back to the title of my book, Humanizing, to recognize that there's humans that are there, that are part of your team. And you're not just directing people to do this, 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 and this. You're engaging them to help you get your purpose and your goal of improving that patient experience. And I'm not talking about so you can get it measured by the insurance companies and by Medicare and that sort of thing. I'm talking about so that the patient actually has that improved experience. And what that ends up with is they comply with your treatment plan. They achieve the outcome that you actually wanted. And it's we haven't talked a lot about that, but the outcome as a patient, again, back to my experience, I could see.
Better health, right? That's what
So
it comes down to.
what's the metric that got there? I'm very happy with that. So I think it's really important that people recognize that. And again, I'm not talking about just the solo practice. I'm talking about the physician that's involved in the Cleveland Clinic or Optum or Ochsner or wherever they would be. That, yeah, up here, yes, okay, the whole reimbursement system, the whole whatever we want to talk about is a mess. What really is important is way down here at that patient level. And every single encounter that every physician has and every employee has is an important part of that process of me receiving care as a patient, leading to the outcome that means that I can actually see again and I can do those things. So without that human interaction, without humanizing, using the metrics, using and understanding the tools and so on that are available to you, what do you get? Patients, as comment that you made, patient walks around and says, I've been sitting here and it's an office, it's a mess. What are they going to do? I'm not going to like the outcome, yada, yada, yada. No, let's change that and make sure that that interaction is there. Let's humanize that and make that 15-minute slot a really exciting outcome so that I can, as a patient, become healthy and wealthy and wise. Not necessarily wealthy, but whatever.
Well, I really appreciate it. Thanks for sharing your experience with our listeners. Congratulations on your new book, one of several. And most of all, thanks for what you continue to do to make the world a better place for patients and team members and physicians. Appreciate your time.
Well, thank you. I really, truly hope that I've contributed in some small way to at least one patient having a better experience.
I am sure we have, and that's it for another episode of All Physicians Lead. If you like the show, please subscribe and we'll notify you about new episodes. In addition, please take a moment to leave us a review so others can benefit from the leadership insights of our terrific guests. See you next time as we continue redefining physician leadership.
This has been All Physicians Lead. We can all be better leaders, and our teammates and patients will be the beneficiaries. Go to allphysicianslead.com to unlock your potential, sharpen your impact, and elevate your journey. All Physicians Lead with Dr. Leon Moores is a production of Forbes Books.